Thank you very much, Philip, and thank you very much to the organisers and the opportunity to present to you today. If you happen to be in the session I presented on Tuesday, this is a good time probably to start looking at your emails and updating your Facebook. A lot of the slides will be the same, but not exactly the same. So I was asked to talk about the example in the UK and very much around how treatment as prevention hasn't necessarily been as successful, which is something we've been looking at. Clearly, we haven't got perfect treatment as prevention, so we're lying a little bit from the start. But I have added another little bit to my title, which is not just about testing, but I think we're forgetting about primary prevention in all of this. So let's not forget about that. I'd like to start very much with acknowledging a wonderful team that I have at Public Health England that helped me with the data and pulled together some wonderful surveillance data in real time. We're very fortunate to have absolutely a comprehensive surveillance system of not only all people that are diagnosed, but people that are subsequently in HIV care at NHS clinics. And those clinics provide data to us annually on absolutely every individual. So we have pretty much a comprehensive cohort of people accessing care in the UK, which is a very powerful data set. These data, with a range of behavioural data, are then used by modelers and others. And I'd like to acknowledge Andrew Phillips, because I'll be using some of his models from the University College London, where he's used the data extensively to also look at the impact of ART on some of the modelling work, which I think will complement David's presentation. But most of all, I'd like to actually thank all the patients living with HIV who actually are part of this surveillance system. And I'd like to apologise for calling gay and bisexual men and other men who may not identify as gay or bisexual but have sex with men, because I'm going to lump you together and call you MSM. So I'm going to give you a small background on the epidemic, focus on MSM for this study. And the reason for that is that we cannot really understand the incidence of our migrant population at this stage, and that's a real struggle, I think, something that we need to work on. Because acquisition of MSM is largely within the UK, it's an easier population to study, but it doesn't mean that we shouldn't be also understanding better other groups, particularly our heterosexual population, which is mostly Black African ethnicity. So the epidemic in the UK, an overview there very quickly, is that by and large, the number of new diagnoses among heterosexuals who've acquired their infection abroad has been on the decline over the last decade, largely to changes in migration patterns, whereas the MSM reports of new diagnoses, as you can see, have been on the rise, and that's been a big concern. The NHS provides free and open access to HIV testing, treatment and care in the UK. That's very important for all groups, and that's something we're very proud of. And the care overall is excellent. Men who have sex with men are the group most affected, with an estimated 18% still unaware of the infection, unfortunately, and around 3,000 new diagnoses a year. And despite a lot of education programs, a third are still presenting with a CD4 less than 350, which is the threshold at which we begin treatment in the UK. Another important point to raise is many of the new diagnosed individuals are actually presenting with acute STIs, so very large morbidity, sexual morbidity in this group. So what would be a successful task? I think I would like to think that treatment as prevention, we would like to see that it would eliminate incidents, all new cases, or at least decrease in a country to say it's been successful. And of course, that's been very much well highlighted by David's talk. In conjunction, though, let's not forget that treatment is all about eliminating AIDS and AIDS deaths, which of course there are far too many. And what we wouldn't want to happen is also that large increases in treatment means that we no longer have primary prevention happening and we start to see very large impacts on STIs. So I would argue that these data are all critical in the assessment of the successful task. We've talked about this slide many times over, and just to mention that with this model, it was almost postulated that the way to reduce incidence is to almost get on treatment as soon as you're infected, not just tested. And that's a very hard call, if you can imagine that. Okay. In the UK overall, this is my lovely slide because I live just around the corner from this wonderful pond. This is the men's pond at Hampstead Heath in London. And it really for me highlights that rather than a cascade, once people are diagnosed in the UK, we are reaching very, very high standards of leaking, retainment and treatment uptake. Particularly in those who need it. Given our threshold is 350, we're not quite reaching 90%, it's about 85% of all people in care are on treatment. And overall, our suppression among those diagnosed is extremely high. So this should be a success story very much, as we've pointed out, what TASC should be about. And if you see that for MSM, the treatment cascade here, for those diagnosed, really we're doing very well. The viral suppression is not quite as high because, as I said, not everybody has reached the threshold for starting treatment. So one could argue we could improve a little bit in terms of viral suppression in those in care, but generally doing very well. In parallel, what we've been seeing with MSM, though, is actually a rise in HIV, but also in all new diagnoses of STI, which is of great concern. Some of that is an artifact because we're improving our diagnostic methods, but certainly we know there is a real rise in STIs as well, and that's a concern. The median CD4 count in MSM has only slightly risen, and that's been mostly in the younger age group, older age group, sorry, but overall hasn't changed very much at around just under 400. However, we have overall increased the number of people who are diagnosed promptly, and that's because we're increasing our testing in gay men. Most gay men are actually tested in STI clinics in the UK. About 85 to 90% of all men diagnosed have been diagnosed in the STI clinic. But one of the things that we've started to do, of course, is to expand testing in a number of community settings, looking at new options of point-of-care tests. To improve that, including home sampling, and some of you will probably know that we have now legalised home testing, and therefore we're assuming that we'll get some of that uptake. But generally, still, it's about most of the testing going on in STI clinics. What you can see, importantly from this slide, and that's one thing we monitor very closely, is the mortality at 1 year, which is the line underneath, is which is a very important marker for us, is very low in the group diagnosed promptly. If we look now at late diagnosis, and these are absolute numbers over the last decade, there's been no change. We're still seeing a high number of late diagnosed individuals, and the mortality rate in that group is much, much higher, up to still 2% in that group. Very unacceptable, particularly in a population of very well educated about testing and supposedly should be coming into the clinics to get tested earlier. So overall, we've done a number of measures to look at incidence rates, and as you know, the challenge to get good incidence estimates is probably what is missing in many, many countries. And the only way to do this really is to try multiple methods and compare them. It's very hard to validate incidence because it really is something we can't do. Since HIV is asymptomatic for many years, it's very difficult to really know the number of new cases unless you model that. We also use a number of tests, such as tests of recent infection, to tell us about the proportion that are new infections within the last 6 months. And we know for gay men that's at least 25% of all our diagnosed cases. But as you can see, it's a fairly flat curve. So even though we've had a large number of, a good uptake of treatment, we've had really no change in incidence of significance. The back calculation of CD4 count has the advantage of giving us also the undiagnosed, and this is the point I think David was making very clearly. The number of people with undiagnosed infection, although you could be convinced here that it's slightly dropping, it's still well over 7,000, between 7,000 and 8,000 if you look at confidence intervals. It hasn't actually changed very much. So despite lots of efforts, putting people on treatment very early, we're still in a situation where we have highest incidence estimates in gay men and very high undiagnosed infections from year on year. So certainly not successful. And why could that be happening? When we look at our viral load distribution, on the left here for gay men, you can see that the majority of gay men are not infectious. This is using a 1500 cutoff, which is probably a bit conservative, but would be just illustrates the example. And of the infective, the 35% infective, if you look at the pie chart, what you can see is that the majority of those who could be infected, infective to others, are all within the undiagnosed, 2/3 are within the undiagnosed population. So the diagnosed population probably contribute very little to potential infections. Of course, this is very simple. We don't understand necessarily the behavioural data, but what we also know is that people who are diagnosed are less likely to pass on virus as well, even if they're not on treatment, because they usually know about their status and usually protect their partners, whereas if you don't know about your status, you're unlikely to do so. And if you look at that over time, and this is the bar of total number of men living with HIV, you can see down the bottom, the red is the undiagnosed numbers that have not changed overall, and the black line is the number of people with a viral load above 50 in this example. And as you can see, around 40,000 men have infectious virus, and most of those are from the undiagnosed, with about 1/3 from the diagnosed untreated. And despite all our efforts and increasing the number of people linking to care and the uptake of treatment over time, which has been increasing, we're not seeing that change at all. Most of that is probably, and this is looking at Andrew Phillips' model now, which, by the way, also shows incidence rates even rising according to this model in gay men here. The model fits the number of data sources that we have very, very closely, showing that number on ART has been going up over time. The number seen for care has been going up very closely, and the data fit very well. But despite that, the incidence has been going up. There's some counter factual scenarios in the models which highlight, particularly on the left here, the very, very large spike is what the epidemic would have looked like if there had been actually no condom use during the time. So this is a big plug for our prevention and continued need for condom use. And this is largely because, again, when you're not aware of your infection, you're more likely to transmit, and particularly during early infection. If we were in this model to increase testing rates in the models, you can see that you would actually decrease incidence as well as starting ART a little bit earlier in those scenarios. In Andrew's model, he's now looked at what would happen if you increase testing rates so that the proportion of people tested at the moment, the baseline is the very light current situation, which is that only about 50% of people are testing within the first year infection, and then it trickles until people are tested into many years into their infection. If we were to have a policy of testing everyone within 1 year, which is very difficult to do still, and everybody was tested within 1 year infection, you would actually get much higher testing rates. What would that look like in terms of incidence, as well as coupling that with starting ART at an earlier time? So this is a bit complicated, but as you can see, the bottom line is even to reduce number of new infections to 1,000 cases down the bottom, our perfect scenario, we would have to test absolutely everybody, every gay man, over 600,000 in the UK, absolutely every year, high testing rate and getting them on treatment immediately. But even then, that would give us 1,000 cases a year background. So clearly there are some issues here. It is, the testing agenda is very important, but what's becoming very clear is that sero-sorting is a very, probably one of the key areas that we need to rethink about. What we've been doing is probably over the years telling people that sero-sorting is not a bad thing, knowing each other's status and making decisions from that. Clearly, people who are positive, sero-sorting with other positive makes sense, but sero-sorting while you think you're negative has probably made more damage to the epidemic than we were aware of. And our behaviour data has not very well tracked that before. And if I could invite Susan Cohen, just very briefly, who's a colleague who does leads surveillance on, in Denmark, where you've been looking at this issue, to highlight how we can really rethink our behavioural surveillance in terms of this issue. Well done. Here we go.
Thank you very much for this opportunity. This is simply a slide of a poster that I hung up yesterday, and it's been taken down, so you don't have a chance to look at it. But I'll try and show you what it's all about. It's the behavioral surveillances that we do among gay men, infrequently, but we do them, you know, with some years apart in Denmark. And what we, oh, sorry, can you hear me?
Talk on the mic.
Talk in the mic, I will. Oh yeah, I can see it here. Sorry. Okay, so what we have been doing in Denmark is the same in principle that you've been doing in most other countries. When you do behavioral surveillance, you think, okay, who is at risk here? What is the risky behavior? And the risky behavior has to do with both condom use, not condom use. That's what I call unprotected here. Unprotected should have been condom-less. I apologize for that. We look at condom use, and then we of course also look at, is there a virus that can be transmitted? So that normally what we've done for years is that we're saying, okay, you have unsafe sex if you have condomless anal sex with a partner who doesn't have the same serostatus as you, as Valerie pointed out, you know, the sero-sorting thing. But now we've changed our minds about that, because we're realizing that, you know, saying that if you think you're negative and you have condomless anal sex with somebody who thinks he's negative, we used to call that not unsafe sex, but we think that this is possibly the most unsafe sex that you could have. So we went and took the data from the 2009 Sex Life Survey and changed the ones that we had called safe sex in this group to unsafe sex. And likewise, it's the purple squares. Likewise, we said, well, if you are on ART, you know you're HIV positive, you're on ART, and you know your viral load is immeasurable, then we change you from unsafe to not unsafe sex. And what happens on the bars? You can see the first bars are about the HIV positive, and the blue bar is the ones who have condomless anal sex at all. The red one is the old paradigm where we say, you know, if you have condomless sex with somebody who is not your serostatus, then you have unsafe sex. That's the percentage of unsafe sex for HIV positive. And the small one, the purple, dark purple, is when we changed it around and saying that only if you are either not on treatment or you don't know your viral load or your viral load is high, then you have unsafe sex. So that changed from high to low, and conversely, for the HIV negative, it changed from low to high, because we said if you have unprotected anal sex with somebody you think is negative, that's unsafe sex. So in conclusion, we have to rethink these data and use them in a new fashion, because otherwise we won't understand what's going on. Thank you.
So the other thing about the whole picture, I think, is the importance of many other factors that we still don't understand, that we don't put as we've talked about, and I've highlighted them here, and I think we've raised some of the questions here. It's a lot more complex, and certainly within the undiagnosed and the early infection and its contribution to incidence, I think is very, very critical. So clearly, TASP in its simple term will not be sufficient, and we've shown that with models and a range of others. It has to be combined, it has to be a holistic approach, and certainly not just looking at testing and pushing testing without rethinking our prevention strategies. In the UK, we've developed an MSM framework looking at the whole determinants of health around why gay men may have higher sexual health, ill health, and certainly issues such as drug, alcohol, chemsex, and a whole range of other issues are to be considered in the HIV prevention framework. Thank you very, very much.